Assalamualaikum and good evening, everyone. Thank you for finding your time and joining our CME organized by CME MedTweetMY Professional. I'm Adila, your moderator for today. Before we begin, I would like to remind if you have any question, you can write in a Q&A box below and we will address your question toward the end of our session. And great news, you will get 1 CPD point from our session today, and we will provide the link for the e-certificate and also CPD point at the end of our session. So, as we know, ischemic heart disease is still the leading cause of mortality among Malaysians. And recently, I actually have encountered a 29 years old gentleman with a ST elevation MI. Of course, the patient has a strong family history and also a smoker as well. So the number of a young adult with ACS nowadays is actually worrying in Malaysia. So for today, we will talk about the acute coronary syndrome in young adults. And today we have Dr. Huzairi bin Sani, a cardiology fellow and also internal medicine specialist from UiTM, to share with us a very interesting topic. He is currently doing his training in intervention cardiology in IJN. Dr. Huzairi completed his MRCP in 2017 and graduated in 2018 from Master in Internal Medicine from UiTM. His area of interest mainly on young onset of myocardial infarction, obesity, and metabolic disease, as well as preventive medicine. So, without further ado, I would like to invite Dr. Huzairi to share his knowledge on SCS in young adult. So, please welcome Dr. Huzairi.
Okay, Assalamualaikum and very good evening to everyone. Thank you for the kind introduction. So my name is Zairi from UiTM. We'll be talking about ACS, acute coronary syndrome, in the young adults. Okay, so I shall share my slide. Okay, so let's go to the presentation. So ACS is not something uncommon to us, but in the young adults is something which is very subjective. When do we say young? Is it 30s, 40s, 50s, 60s? So my presentation will be a bit on the definition, the statistics data, and we'll go through some cases as well as the management. Okay, so we will start. I have nothing to disclose. So I would like to start my presentation with this authentic hadith. Verily in the body there is a piece of flesh. When it is sound, the whole body is sound, and when it is corrupted, then the whole body is corrupted. Verily it is the heart. Okay, so this is to emphasize that how important the heart physically as well as spiritually. So everyone has a heart, and we all have been appreciating it since it has been pumping and working from the day we were born. So a bit on the heart muscle over here and coronary arteries, as we all know. So we go through a bit of the definition, types, pathophysiology, as well as the young adults definition. Okay, so acute coronary syndrome is a clinical spectrum of coronary artery disease that develops because of imbalance between myocardial oxygen demand and supply. So it is further classified into unstable angina, STMI, as well as STMI. So that is we all know. The burden of this disease is not only in Malaysia, but also throughout the whole world, where according to WHO, almost 80 million people died from cardiovascular disease. And in Malaysia also is the leading cause of death, except during the COVID era when COVID death was more than cardiovascular diseases. So we'll go through a bit of the statistics for the past more than 10 years. So you can see from this graph taken from the NCVD ACS registry year 2018-2019, this was the latest published. You can see that this graph, the dark blue as well as this orangey color chart represents almost 50% of the burden of ACS. Okay, so here we can look at, actually the chart is less than 60 years old. Okay, so almost 50% are those who are less than 60 years old. Okay, so this is something worrying and alarming, because since 2006, okay, more than 10 years ago, the burden has been affecting the same age group. So we would need to do something more drastic, which can give an impact to this statistics, and we have to do something urgently, right? When we look at the mean age group, okay, you can see that this mean over here is 58.6 into 16, 58.6, and also 58.7. Okay, so the mean age group is 58.7. Those are age below can be considered as young. Okay, but is this 58.7 years of age, is it young or is it old, or is it, how do we know whether is it a young ACS, or is it okay to have ACS, or it's not acceptable? So we will compare with other countries, our neighboring countries, as well as the Western countries. When we classify according to the gender, so you can see that majority of the patients are those in male category, right? So this is something worrying. And so you can see here, mean age 58.6, there's some small amount less 1%, less than 30, less than 46%, and less than 50 is 17%. Okay, so how about our neighboring countries? Okay, Thailand 63.5, okay, and Singapore 68 to 69 years of age. Okay, so that is like 10 years older than our median age of ACS. How about those in the Western countries? Okay, so you can see from France, okay, fast MI, okay, non-STEMI in-hospital mortality is only 1.9%. Okay, Czech Republic, non-STEMI in-hospital mortality only 4.1%. Greece, okay, from the Global Registry of ACS, only 2.9%. And ours here is, since 2014 has been 8%. Okay, so this is like 2-3 times higher compared to the Western countries. It's also similar in 2017. In the US, the median age group for ACS is 68, is also 10 years older than our population. So this is something worrying. And when we look at the types of the ACS, we classify STEMI 8,000, non-STEMI 6,000, and non-stable vagina 5,000. So still the burden of STEMI is the highest compared to the other two. And of course, STEMI is more life-threatening and higher mortality rate. Okay, compare the other two. And we look at the risk factors. Only 6.5% without risk factor, and others are at least with one risk factors. So these risk factors are defined as presence of dyslipidemia, hypertension, diabetes, family history of premature cardiovascular disease, smoking, and obesity. And so two risk factors are two or more, or three risk factors, and more than three risk factors are those with lipid, hypertension, diabetic, and smoking, obesity. So it doesn't mean that those with a higher risk factor from this data, it doesn't mean that those with a higher risk factor are more predisposed. It means that even those with only one risk factor are at higher risk of developing ACS. Okay, so you can see that here one risk factor. Okay, so already almost 5,000, which is almost equivalent to those with three risk factor. Okay, so that's why sometimes when we deal with young patients. They will come to you and say that why would they have MI, why would they have a heart attack, why would they have a ACS. Okay, they will say like, doktor, saya isap rokok je, tak ada pun kecil manis, darah tinggi, kolesterol, tapi kena serangan jantung. And then they will also compare with their friends, say, okay, kawan saya tak bersukan, badan besar, kecil manis darah tinggi, tapi tak kena serangan jantung. Okay, tapi kenapa saya? So, doesn't mean that more risk factor would cause ACS. It means that only there's even one single risk factor would predispose patient to develop ACS. So this coronary artery disease, we'll go through beyond the pathophysiology. Stable angina is when there is narrowing of the vessel of the coronary artery on patient's exertion, meaning that when the heart is in demand or pumping or requiring higher oxygen, then patient would develop symptoms. So that's why the onset is usually weeks or months, or even sometimes would take years. Okay, and the symptom occurs when patient exert themselves. Okay, so when we classify angina by definition, so we can say it's a typical angina when it fulfills these three criteria. Okay, constricting discomfort in front of the chest or in the neck, jaw, shoulder, or arm, preceded by physicalization and relief by rest or nitrate within 5 minutes. So atypical meet only two of these characteristics, and angina chest pain is only one or none of these characteristics. So this is very important because I personally having problem in getting history from patients, okay, when the symptoms are not very clear, you say, and they come with sesak nafas, dada sempit, ketat, semput, and it's not like the typical symptom. But we can use this as a reference when we clot the patient, right? So we will discussing more about acute coronary syndrome. So we will talk about more of unstable angina, non-STEMI, and STEMI. So what happens in unstable angina? There is a sudden chest pain. Okay, why? It's because there is a plaque rupture or ulcerated and cause thrombus formation. Okay, so the difference is there is no infarction. Okay, in unstable angina, when there is no myocardial injury, there will be no elevation of troponin level. When the narrowing or the thrombus or disease is small, that would extend the cause of injury to this myocardium, that would lead to non-STEMI, where when we do a troponin test, will be elevated. Okay, so STMI is a total occlusion, so 100% acute occlusion of the vessel. Okay, so this pathophysiology is very important because we will apply to our management on the investigation and as well as on the treatment. Okay, so why we offer thrombolysis, why we offer primary PCI, why we go for functional test first for unstable angina, and when do we go for coronary angiogram in case of NSTMI, right? So the image on the left, okay, we can see that when patient has a chest pain, when we think of ACS, so the coronary vessel, right, is not totally occluded in case of non-STEMI, okay, where it can be due to unstable angina or an STEMI ACS. When there is total occlusion, like in this picture, 100% block, there will be S elevation, and this is when we diagnose STEMI. So at this time, we don't need the troponin to come back before we come to the diagnosis of STEMI. So when a patient comes to us, they can present to the GP or clinic kesihatan or emergency department. They can come with typical symptom, well, they can go to green zone. At the same time, they can also come in collapse, okay, when patient develops sudden cardiac arrest that requires CPR. And we have to then further investigate, is it a true cardiac, non-cardiac, is it ACS, non-ACS, and what type of ACS, okay? So we'll then proceed with ECG if patient is stable. If not, we have to resuscitate patient first. And then we will do troponin if it's non-elevated, stable, elevated, non-STEMI. And if it's ECG ST up, it's STEMI, right? So when patient comes, right, so we can immediately tell that by the look of the patient, whether is it a true ACS or not, right? And by looking at the patient, also we can roughly know whether is it a STEMI, non-STEMI, or stable angina. Okay, when the typical is the Levin sign, okay, which is typical of ischemic chest pain. And this is an image to show that the management, okay, ACS, abnormal ECG, clinical context, as well as how stable is the patient. And then once we have diagnosed, is it a STEMI, high risk non-STEMI, or high risk ACS, we offer primary PCI or fibrinolysis, immediate angio PCI, or early angio. So the treatment is double antiplatelet, anticoagulant therapy, as well as revascularization, whether it's PCI or CABG. We'll discuss on this later with some this example, and also secondary prevention, okay, on the steps to prevent it from happening the second time. Okay, so in this image, you can see that sometimes patient come with various chest pain. Okay, sometimes they say that right-sided, left-sided, ulu hati, leher, belakang, shoulder, and we are not sure sometimes is it a true cardiac pain or not. Therefore, we need to further do investigation by doing ECG, which can be repeated, and also we can do blood tests, troponin. Okay. What I highlight here is patient on presentation. We can do troponin level at 0 hour, and if the troponin comes back as negative, here we can repeat the troponin level at 1, 2, or 3 hours. Okay, because we know if it's a true MI, the troponin will be elevated. So depending on the onset of the symptom. Okay, so if we have two results of negative troponin level, then we can rule out MI. And if it's non-cardiac chest pain, we can actually discharge patient from the emergency department. Okay, and then if it's there is ST changes, then it is more likely due to unstable or non-STEMI. If it's a STEMI or patient comes in unstable, then it's straight away we need to stabilize and do an ECG. Okay, so I'd like to share a case, patient which I have shared this case a few times because it's a very, would say, sad and surprising, as well as devastating. Patient came in unstable, fitted emergency department, and he was pulseless, no spontaneous breathing. So he was first in the green zone and transferred to red zone, and cardiac monitor was applied and showed malignant arrhythmia. So he was shocked, CPR, and fortunately, and there was a return of spontaneous circulation. So this was a young gentleman, okay, born 1987, a teacher, presented with epigastric pain only, okay, and non-smoker, gout with a family history. Did an ECG, so you can see there is ST elevation as well as ST depression. Okay, so ST elevation at 3 AVR and also ST depression widespread. And because of this, they decided to intubate the patient and plan for revascularization therapy by thrombolysis. Okay, patient was unstable, required inotropic support, a double antiplatelet given, taxane, and also tenecteplase because BP was low in cardiogenic shock. Despite on thrombolysis therapy, patient remains unstable, that they need to be resuscitated and then referred to a heart center. Okay, so patient was transferred and put on an external automated CPR. Okay, as you can see, like in this image down here, and a coronary angiogram immediately was done. So this image showing that there is a total occlusion at the proximal left anterior descending artery, and it was emergency procedure that we need to put in a wire down to the left anterior descending artery, open up the vessel with a balloon, and only that we can establish flow. Okay. Then we wonder why would a 36-year-old gentleman with a life-threatening acute ST elevation MI failed thrombolysis and had to refer for rescue PCI. And we sent the blood test as well as other risk factor. Patient was obese, total cholesterol was 7.1, high triglyceride, LDL was 5.5, HDL 0.7, good cholesterol should be higher. Also has evidence of fatty liver, and his HbA1c was okay. He was non-diabetic and non-smoker. So what if it's not a STEMI? So sometimes patient may also come with arrest, okay, but may not be only due to the heart. Okay, it can be also due to stroke, could be due to motor vehicle accident, could be due to sepsis, and if there is no ECG changes after resuscitation, it may not be due to the heart attack. Okay, so we have to depends on a case basis on what is the reason of patient going to cardiac arrest. Okay, we go to the next case. This case was referred to us recently during my on-call. So this is a referral letter originally taken, referred to IJN of 32-year-old male, no known medical illness, right? So as well as he's a non-smoker. Okay, presented with acute chest pain, 9 a.m. And this is ECG. Okay, so you can see that ECG, ST depression, 2, 3 AVF, ST elevation, V1, V2, V3, V4, bit of V5. Okay, troponin was very high and referred for primary PCI. Okay, so 32-year-old, very young, we accepted the case. So this is to highlight again that when we have a case of STEMI, is due to acute occlusion, okay, total thrombosis. Okay, so this will cause the ST elevation. In case of non-STEMI, there is still opening which is narrowed, but there is still flow. Okay, and ECG will show some ST depression and raised troponin and diagnosis of STEMI. Then we proceeded with primary PCI for this young gentleman, where the access will go through the right radial artery all the way up, catheter under fluoroscopy to the aorta, and then we will inject the arteries, coronary arteries, right and left. Okay, another option is via the femoral. Okay, so this is image on the left is the coronaries of the right side. Okay, so if we can appreciate there is a narrowing here, okay, at the proximal right side, but there is still flow distally, right? And we need to remember that The ST elevation was at the anterior, right? It was an extensive anterior ST elevation on the ECG. So the culprit vessel in this case will be the LAD. Okay, so LAD is supposed to be coming down straight like this, but now there is a total occlusion where the contrast upon injection cannot flow distally. Okay, so there is a thrombosis here, so 100% occlusion. Option again, if it's a STEMI, it's a thrombolysis or primary PCI. Then we wire down this LAD artery, and now we can see there is some flow coming down, and the most tightest part is here, okay, at the proximal to mid LAD. Okay, then we proceeded with the aspiration balloon and this image of a stand. We need to deploy a stand size, and then now we have established the flow for the LED. Okay, so remember the image was in the first diagnostic angiogram was occluded. The vessel was occluded from the proximal part. Now you can see the flow has established to the mid and distal part of the vessel for the myocardium to pump again. Okay, so next we go to the cause of a 32-year-old. Why we develop a MI? Otherwise, kidney is fine, liver is fine, sugar is fine, except for the cholesterol. Remember, it was also a non-smoker. Total cholesterol was 6, LDL was 4.1. Okay. On the same emission, so remember that we took a shot of the right coronary artery, and where we found that there's also a significant lesion, stenosis on the proximal part of the RCA. Okay, well, it's not totally occluded, but it's also very tight. Looks like there is a plaque, atherosclerotic plaque at the mid part, right? So again, put a wire distally, then also needed a stent. Okay, so now we have opened up. Now the vessel has gotten bigger. So this to share that the group message when we receive a case of primary PCI or acute PCI, where we need to activate the lab, there will be a group of people that is involved, which is the radiographer, the MLT, CVT, doctor, and also the staff nurses. Okay, so this is 35-year-old gentleman. This is 31-year-old, 38, and also a 38-year-old gentleman. So you can see that the patients are now much younger than the our median ACS age group from the National NCVD Registry. Okay, so taken from the 2021 Malaysian CPG. So when we have a patient with chest pain after history and physical examination, we proceed with the ECG, and if it's not a STMI, we can send troponin. Okay, so if it's a troponin, high troponin, immediately emit. So we don't have to repeat the sample. Okay, so if the troponin is okay, normal, then we can repeat the troponin depending on the onset of symptom. Okay, because if patient develop symptom of more than 4 hours, we will expect the troponin to be elevated. Okay, if it's not elevated, then we can repeat the sample again. Okay, so we can repeat within 1, 2, or 3 hours later. So here, repeat second at 3 hours or repeat at 2 hours later. And if it's elevated, then a diagnosis of NST, ACS requires admission. If it's still low or normal, then we can go for a calculate risk score. Okay, by heart score or TIMI score. Okay, so if heart score or TIMI score is high, then we need to admit the patient. If patient is pain-free and heart score is low or TIMI score is low, then we can discharge from ED for early outpatient cardiology. Okay, so sometimes it's not easy to discharge patient from ED. Sometimes also we are worried what if it's a true ACS. But if you follow these guidelines, we have repeated throb, patient is pain-free, low risk, so it is safe to discharge patient from ED. At the same time, we can also advise the patient, okay, kalau ada sakit dada, you can just come back anytime, because sometimes outpatient appointment is not early. It's not easy to get an early appointment, so we can advise the patient if there's any symptom, can just come back to the hospital as soon as possible. Okay, so this is the risk score for TIMI as well as a heart risk. So I personally don't memorize this risk score, but we can also always use the phone to calculate. And once we get used to it, then you can easily tell whether it's a high risk or low risk. Okay, so these include the history, ECG, age, risk factor, as well as the troponin level for TIMI. So it is all. So you can choose high or you can use TIMI. So the easier one or the widely used is the TIMI risk. Okay, so age more than 3 risk factor, non-CD more than 50, aspirin presentation, and ECG and also troponin. So if it's high, when it is more than 5 to 7. Okay, when risk is 26 to 41%. This is a risk score. Okay, with this a prediction of risk of death and myocardial infarction. So gray score is when we sometimes use to decide when would a patient go for a coronary angiogram. Okay, so we have an established or high concern for non-STE acute coronary syndrome, and usually it depends. Where is the patient? Is it patient in a heart center or non-heart center? Non-heart center meaning that those without catheterization, cardiac catheterization lab. Okay, so when do we refer and when do we discharge and when do we how urgent do we need to refer? Okay, so those non-STAMI or non-STACS, very high clinical risk. Hemodynamic stability meaning the patient needs inotrope. Okay, there is a ventricular arrhythmia. Okay, VT, VF, acute heart failure, and medically refractory angina. So persistent chest pain. Then patient needs to be referred for invasive strategy, which is coronary angiogram, angioplasty less than 2 hours. So just you can even call you can refer heart center for non-STEMI if they have these features. Okay, so do not admit to CCU first, continue observation medication if a patient have this criteria. Okay, so you can straight away refer to a heart center and the indication is for angiogram, angioplasty. So sometimes they are more stable. Okay, more stable. Okay, chest pain not so bad, BP not supported, but ECG changes or high troponin. So early invasive strategy, so less than 3 hours. And if it's a low or intermediate clinical risk, TIMI risk low, risk score is low, then we can do it more than 24 hours. Okay, so this is almost similar to our local guideline, which we can refer to in the termination of densities VG 2021. I'm going to go through and we'll discuss on this case. Clinical case for a 2-year-old, okay, so relatively young. Diabetes mellitus, hypertension, default atrium, e-cigarette smoker, right? And lifestyle chest pain for 1 day. So this gentleman came with chest pain, but looks very comfortable, was playing with his phone, and the symptom wasn't typical. So, cucu-cucu, ada sikit sederhana, much better. bila baring lagi sakit, bila duduk okay, and troponin repeated twice was same. Okay. Anyhow, due to the high suspicion, also high risk score, patient was admitted and given double antiplatelet, Fonda, echo, as well as chest X-ray. Okay, so aspirin is a class 1A and plus or, okay, one of it, P2Y12 inhibitor for the second antiplatelet, as well as anticoagulant. Okay, so if we have echo and poor EF, we can start on beta blocker, ACE or ARB. If it's EF or TOLO, sometimes we don't have, so it's not necessary to start on beta blocker, ACE or ARB. Right. So this was his ECG. Troponin was 36 to 36, and ECG repeatedly a few times was also this. Day 2 of admission in the ward, there were ECG changes, okay, evolving changes. Still typical, the symptoms wasn't very clear. It was on a Saturday morning, and looks, when you compare, there is ST elevation at the V2, V3, V4, and also V5. Okay. So then patient was decided to brought into the lab for coronary angiogram. So this is coronary angiogram of the right side, RCA. Okay, so it's supposed to be like a C shape, right? But now there is a total occlusion here, right? But also we need to remember that the ECG that patient had evolving was on the anterior side. Okay, so anterior side. But now on angiogram, we have a total occlusion of the right side, and but the ECG showed on the it was an anterior territory. So this image of the left coronary system, so you can see that there is a subtotal stenosis over here. Okay, so this is almost like we say 99% stenosis lesion at the proximal to mid LED here. Okay, so this one and this one, so we have to we think that this is the culprit that caused the chest pain as well as evolving ECG changes. Okay, so we decided to intervene the LED. Okay, so most probably this right side is chronic. Okay, chronic, which is not acute, therefore it's not the culprit in this case. So we also have a look at the left circumflex artery. You can see that there was also very tight stenosis here at the mid circumflex as well as the OM1, okay, of this margin 1. If you can appreciate, there is tight here. Okay, so this gentleman at 42 years of age, right, he has a total occlusion, total block of the right side, 99% block of the LED, as well as here 90% stenosis at the circumflex. So patient has 3 vessel disease, and what you have to do is we need to, because patient is a STEMI patient, we need to open up the culprit lesion. Okay, so this is wire down the left anterior descending artery, and then we open up with the balloon, okay, at the tightest area, and then we establish flow. Okay, so due to multivessel disease with diabetic, so this gentleman was referred for coronary artery bypass graft. So at 42 years of age, patient is due for CABG. Risk factor, obesity, is cigarette smoker, uncontrolled DM, as well as cholesterol 6.8, LDL 4.3. So this is also a very young case. So next case is a 30-year-old gentleman, okay. Also presented with chest pain. So this is chest pain was at 2 a.m. Typical, no use of recreational drugs or any supplements. ECG showed ST elevation. He was 27.5. Okay. So is coronary angiogram total occlusion of the LAD, and then we implanted a stent, okay, a DES drug-eluting stent. You can see that the now LAD flow has been established. So we wonder again why a 30-year-old would develop a ST elevation without any risk factor. And true to our thought and hypothesis, we found that there is a genetic predisposition for this gentleman when we compare with the genome-wide acquisition study, that the patient carries gene of young myocardial infarction. Okay, so this case was published in the MGMHS. So next case is 53-year-old lady. Yeah. Okay. So for remember, most of patients are men. Okay. This lady. So therefore, this is also a relatively young patient, right? And you can see that from the angiogram, so patient presented with non-STEMI. So non-STEMI, there is no acute total occlusion. Okay. But there is very significantly diseased vessels. Okay, so this is the one on the left here is the left main. Okay, you can see that over the left main before goes down to LED and circumflex here. Okay, so there is a tight stenosis here at the left main. And also you can see that the vessel is narrowed throughout the vessel, meaning that it's diffuse disease from the start till the end, from proximal to the distal. Okay, so from the start till the end, okay, it's very small and thin vessel. So this like typical feature of diabetic patient vessels. Okay, so and it affects the all three vessels. Okay, so sometimes not only they come with suspicion of one coronary artery disease, but they actually had other disease, other vessels are affected too. Okay, so the best for this lady is actually we wanted to do a bypass for her, but due to multiple reasons, chronic kidney disease, hospital acquired pneumonia, and many poorly-controlled DM. So from the multidisciplinary meeting, CBG was not an option for her. Therefore, we proceeded with high-risk percutaneous coronary intervention. Okay, so this on the left is before we intervene, and on the right is the vessel after we put in a stent. Okay, at the left main LED as well as the circumflex artery. Okay, so you can see on the left is before and on the right is after. Okay. So when a patient presented with ACS, so what we know is there is a plug rupture or plug erosion, right? And there's also thrombus formation. Okay, plug rupture, plug erosion, and thrombus formation. So we need antiplatelet as well as anticoagulant. So aspirin or clopidogrel, ticagrelor or pasural is a P2Y12 receptor, and anticoagulant. Okay, whether it be fondaparinux, heparin, and or Clexane. Okay, there is no study yet for the direct or anticoagulant oral. Studies are ongoing before we can start using the other DOACs. Okay, so we need to stabilize the plug, and also we need to resolve the thrombus that causes the ACS. Okay, so again, depending on the type of ACS, unstable angina, NASD, or STEMI. So first option is if it's a STEMI, so primary PCI +1, and if it's a non-STEMI, we can decide whether angiography early or later, as 24 hours, more than 24 hours. Antiplatelet will be aspirin by default, and also P2Y tough, whether it is clopidogrel or ticagrelor, and only proceed with the invasive coronary angiogram. And ACS default double antiplatelet strategy for the first 12 months after ACS, aspirin plus P2Y12. Okay, so it is ACS still will give duration of double antiplatelet for 1 year. Then after 1 year, continue with single aspirin. Okay, so unless there is bleeding or any other reason that needs to stop, only we consider to give less than 12 months. Okay, so this slide is to share on the secondary prevention for those who have suffered ACS before, to prevent from it happening again. Most important is lifestyle medication. Okay, so lifestyle medication include stop smoking, weight reduction, physical activity, stress management, depression counseling, healthy diet. Okay, so it is not enough if only patient do the others, but leave one, but they need to do all to prevent another ACS. Okay, some patients say that saya dah buat healthy lifestyle, but they miss their medication. Okay, so still doesn't work. So it still has to be a holistic approach. Okay, for the pharmacological therapy, antiplatelet, lipid lowering is intermittent beta blocker if the EF is affected. Okay, of course, BP and sugar control, and LDL target, okay, will be less than 1.4. So next, importantly, is referred to cardiac rehab, when the patient will be assessed according to the stage. Okay, so that they can return back to their normal lifestyle. Okay, so sometimes patient comes to me and then cakap, doktor saya nak light duty, doktor saya nak saya tak boleh buat kerja berat, doktor saya nak kerja ringan, nak MC extend. So actually we want them to be active again. We want them to go back to a healthier, a better lifestyle. So we don't want them to become more sedentary. So we can do that by referring to the cardiac rehab, and then they will see the patient's progress. Okay, so this is my last slide, take home messages. First is coronary disease, leading cause of death in Malaysia. And the mean age of ACS is 58.7-year-old in our country, which is younger, okay, compared to our neighboring countries as well as our Western counterparts. And now we are actually seeing more and more younger patients. So why is it still more and more younger patients? It's due to our lifestyle and our traditional risk factor, meaning that smoking, obesity, diabetes, hypertension, and less on the genetic or non-modifiable causes. Okay, so high prevalence of CAD risk factors. MI in young could be due to genes and environmental interactions, because this is the future of research, when we need to study more about the genes on relation to the onset of ACS. Okay, because sometimes patients may have other risk factor, but they have early onset. Accurate diagnosis determines mode of revascularization, whether it's a STEMI, non-STEMI, or unstable angina. And of course, primary and secondary prevention is the key. Okay, the second onset of ACS, second episode will be a more higher mortality as well as morbidity compared to if it's a first ACS. Okay, with that, I thank you very much for your kind intention.
Thank you very much, Dr. Huzairi, for a detailed explanation on SCS in young adult. It's definitely worrying. Given that even our mean age for the ACS in Malaysia is already, lower, 58 years old compared to the neighboring country, and then we have a lot of cases. Just now that you've shown to us, all like 30 plus years old. And I think in all centers, everyone also have encountered such patients. And of course, we have referred them to the cardio center for further treatment. And if you have, so I would like to remind, if you have any question, you can write in a Q&A box below. And for the Q&A, I'll pass the floor to Dr. Faiz. Okay, please welcome Dr. Faiz.
All right, thank you, Dr. Adila. And again, thank you very much, Dr. Huzairi, for very insightful lecture. So we got a number of questions tonight, Dr. Huzairi. But again, I'd like to emphasize to our participants, we tried our best to pick the questions that give the most clinical relevance to be answered. And we try to answer all the questions provided time allows. Okay, so I think we jump to our first question first. Okay, Dr. Huzairi, in your opinion, which one is cost effective in long term, primary PCI or thrombolysis?
Sorry, come again. What was the question? Which one is more effective?
Cost effective in long run, primary PCI or thrombolysis? Cost effective.
Okay. The best to answer that question is we should not take cost as a limitation. Because when we are dealing with the heart, obviously it is priceless, meaning that we would pay as much as we can afford to have a healthy heart. Therefore, between primary PCI and thrombolysis, primary PCI will be the better option, and cost should not be a problem or limitation. In case that, if cost is an issue, I think we have other alternative where we have in the country private sector, semi-government or government hospital. So we can always refer to a government hospital.
Yeah, all right. Thank you, Dr. Huzairi. Again, we can either refer to KKM hospital for those with a cost problem, or in our, I think, university setting, we got our welfare also to help sometimes. Okay, so to the next question. Do patient need anticoagulant before primary PCI?
Anticoagulant, okay, so not necessary. So if patient is planned for primary PCI, so most important is the double antiplatelet. Okay, because why we need double antiplatelet to load the patient is because we need to prevent stent thrombosis. Therefore, when we have a patient, it's always important to load patient with double antiplatelet. Sometimes we even load the patient on the table. When patient is in the lab, we serve patient double antiplatelet if they are already not on. Anticoagulant is not a necessity, but of course we would not sure. Sometimes patient comes whether patient will go for primary or patient go for thrombolysis. If patient is for thrombolysis, then we straightway go for thrombolysis therapy.
Okay, all right, understood. And then on to the third question: which thrombolytic agent is the best in acute MI?
Depends on availability. Of course, now we are moving away from streptokinase lah. So depends on the availability. So I think majority of KKM hospital still using streptokinase. But if there is an option, then we will not give streptokinase.
The other option that we can give, again, Dr. Huzairi, is metal-less, isn't it?
Yeah, that's right.
Okay, all right. So,
But it's also because of cost and the availability of the medicine.
okay. So I think we move to the fourth questions. Do all MI have coronary thrombosis?
All MI has coronary thrombosis.
Do all MI have coronary thrombosis?
Okay, so if it's STEMI, ST elevation myocardial infarction, then it is acute total occlusion of the coronary because of thrombosis. In case of NSTE ACS, there is also a thrombus due to plaque rupture or erosion, but it's not occluding the vessel 100%. Okay, so there is a thrombus which not obstructing the vessel 100%. That's why in case of NSTE ACS, we still give anticoagulant because we not only want new platelet aggregation at the site, but also we want to give anticoagulation to dissolve the thrombus at the coronary artery. So I hope that answers the question.
Okay, okay. I think our questions keeps on increasing in the Q&A box. Again, I'd like to highlight to the participants, we try our best to answer all, but due to our limitation of time, we pick those with the most clinical relevance. Okay, on to the next question. Some young MI cases seems to be isolated case. Any additional screening in the future that you would suggest, Dr. Huzairi? For example, genetic study?
Oh, okay. Genetic study still a long way to go, but we do have the facilities and also service in UiTM Puncak Alam, I promise, to do genetic study. But of course, genetic study is still a lot of things that we need to establish the association with our population and also young ACS. What we already know are the traditional, we call it traditional risk factors, that which is still a high burden in our population. So for me, I think genetic is not in the anytime soon. What we need to focus is still the usual diabetes, hypertension, cholesterol, and so on.
Okay, all right. Yeah, I mean, focus on the main thing first. I think because our youngsters, I mean, mostly have a sedentary lifestyle, and most of our young MI, they have their own culprit, like example, dyslipidemia and hypertension and stuff. And
That's right.
And then, okay, salam doctor. If patient already on DOAC and then develop ACS, do we start the APT and stop DOAC, or start the APT and continue DOAC?
Okay, so that's a good question. For those already on DOAC, we can give triple therapy for 1 week, and then followed by double therapy, which is antiplatelet plus the DOAC. And after 1 year is the DOAC. So so we still continue the DOAC, and long term is still, if there is indication for direct oral anticoagulant, then we will continue with the direct oral anticoagulant.
Okay. All right. Okay. So in the case of MI patients with high bleeding risk, is antiplatelet still recommended, and what's your take on this?
Okay, so there is a scoring system for high bleeding risk, HBR risk score. So there are many things that we need to consider if we are worried of bleeding in the patient. So one is the patient punya background. What is the bleeding risk? Is it because of kidney disease, or is it because of cancer? Is it because of anemia? Is it because of age? Okay, that is the patient's clinical profile. Number two is the options of antiplatelet and anticoagulant. Number three is the PCI itself. We not sometimes now we have DCB or drug coated balloon that we don't put in a stent in the coronary. So when we put in drug coated balloon, which is coated with medication and deploy at the vessel, there's no foreign body left inside the coronary artery. Therefore, the duration of antiplatelet can be shorter. So those with higher bleeding risk, those patients with tendency to bleed, then we can shorten the duration of antiplatelet to 1 month, 3 months, or 6 months. So according to the patient's bleeding risk.
All right. Okay. I think I just take another 2 or 3 more questions. Okay. Although we got, I think more than 5 questions down the line still. Okay.
Maybe you can email the rest of the questions. Maybe.
So okay. Dr. Huzairi, what sort of exercise to advise post ACS? To what extent that you mean being active post ACS? Because sometimes we are worried about exercise induce another ACS event.
Okay, so also very good question. So the EAC guidelines, they classify the exercise punya level according to the intensity. Okay, you have a light intensity, moderate intensity, and high intensity. Okay, so if it's a post ACS, so we obviously don't want the patient say we go to a high intensity or moderate intensity sports. Okay, so what is the best advice is usually to the patient, we can ask them to do the usual chores. That would not be any problem. And we have to compare with their baseline. Okay, some people their baseline is, you know, sometimes they are athlete, their baseline is 3 km, 5 km, 10 km punya run, which they can do before ACS. Some people who are elderly, their routine is just brisk walking. Okay, that's their baseline. So according to the patient's baseline, we would want them to go back before they develop the ACS, or even better, but gradually. Okay, so we always tell the patient that we ask how are they before they got the ACS. So if patient is only usually do brisk walking, and then we will not ask them to, you know, go for jogging or running. If they are only used to 1 or 3 km, then we would not ask to go for a higher intensity 5 or 10 km. So we want them to go back first to their baseline, but in a gradual manner. So usually there will be stages that the cardiac rehab will assess. Usually they will go on treadmill, walking, or cycling, where they will be monitored according to their heart rate. So their heart rate tu, dia akan ikut dia punya stage of the heart rate. So depending on that, then they will increase the target heart rate in the following appointment.
Okay, I mean the keyword is back to our baseline and gradually improve from there. Okay, sorry, Dr. Huzairi. One last question, because a lot of interesting question here. I just pick one lah. How does vape affect coronary risk from your personal experience, or I mean mungkin ada any form of data or whatnot, vape and coronary vascular risk?
Vape,
Yeah.
Okay, vape is a very interesting question. It's just that vape ni is a new friend enemy. Okay, so when we don't know the exact association or cause yet, like cigarette smoking, when we have known them for many years, right? So initially macam kawan lah kan, dulu-dulu kawan, and then lepas tu then dah tahu actually dia actually not kawan, it's actually lawan. So when cigarette smoking can cause cancer, can cause stroke, can cause peripheral artery disease, can cause heart attack, right? So that is because of many years of experience or many years of research and association of cigarette smoking to these diseases. For e-cigarette or vaping is something which is new still. Therefore, more research or case report are needed to have the association between vaping and coronary artery disease. Okay, but so when patients or anyone ask that, I usually say that between the three, smoking, vaping, and non-vape or non-smoker. So of course, the worst is smoking, least is vaping, and the best is none lah. Okay, so kalau patient tanya, then you say that okay, antara rokok dengan vape, then so far vape is safer than rokok, but between tak vape dengan vape, then tak vape is better. So sometimes it's challenging or interesting when we deal with young patients, because they have their own ways and thoughts. So we also have to answer them in a way that they want.
Alright, okay, understood. Okay, I think that's that for our Q&A session. I think we exceed our 15 minutes already. Thank you very much, Dr. Huzairi. I pass.
Thank you very much. Thank you, everyone.
Adila,
Thank you for the opportunity.
Okay, actually, we have almost 20 questions tonight, so that's a lot. So I would like to congratulate Dr. Huzairi, maybe for the very detailed explanation that everyone love to ask the question. So, but we have to keep it short because our session is almost due. So on behalf of everyone, I would like to thank our speaker, Dr. Huzairi, for a very clear explanation on the SCS in young adults. So now we have come to the end of our session. Thank you for spending your evening with us. We have shared the link for the e-certificate and also CPD point in a chat box. We open the link for 30 minutes, so you can get your CPD point from the link. And also, as a conclusion, we know that the cardiovascular is still the leading cause of death worldwide, including Malaysia. And of course, the number of young adults is increasing. And also, Dr. Huzairi already mentioned regarding the primary and secondary prevention. So as a healthcare worker, we have to take part, to prevent and also educate our patients as well. And actually, I have a question, sorry, last before ni, regarding cardiac rehab. Which center that now has a cardiac rehab, so that we can, and what kind of patient that we can refer to cardiac rehab? I mean, from a government hospital?
Yes, so in UiTM, Sungai Buloh, we have cardiac rehab. Also in UiTM Puncak Alang. So I think I'm not sure about other universities, but other established heart centers would also have cardiac rehab facilities. So can refer to us in UiTM Sungai Buloh.
Okay, what kind of patient that we should refer? Is it like all ACS or MI patient? Or
those actually, and those patient post STMI can refer for all patients of STMI can refer for cardiac rehab.
Okay, all right. So we can refer to the cardio center lah. Okay, so with that, I would like to thank everyone again, and thank you for joining us. And thank you, Dr. Huzairi.
Thank you. Take care. Assalamualaikum.